Good afternoon, ladies and gentlemen. Welcome and thank you that you are joining today's live surgery webinar. My name is Thomas Müllner. I'm country manager for Balkan, Hungary and Austria for Johnson Johnson Vision. As you are all aware of this difficult situation in 2020, this live surgery event is part of a new platform we have created to give our best surgeons room to share best practices and experience and learnings. Our aim as Johnson & Johnson is to provide state-of-the-art innovation and premium products to help surgeons deliver best results and sustainable value to our patient. And that's why we decided to present together with one of our major partners, Svjetlost Klinik, our new technologies. I would like to thank Professor Gabrić and his team for such a great event together with us. Today's moderator of Svjetlost Klinik is Professor Dekaris and Professor Lazić. Also a warm welcome and thank you for your support. From Johnson & Johnson side, it's a pleasure to welcome our Vice President of EMEA region, Ms. Erin McAshrin. Welcome, Erin. Great that you also join us today. Also, I would like to welcome Dr. Andreas Reichert, our Director of Professional Development in EMEA, who will take over then and support us as a moderator from Johnson & Johnson side during this event. Let me give you a quick overview of Svjetlost Klinik. The Svjetlost Klinik of Professor Nikica Gabrić has more than 10 years of partnership with us. The clinic has 6 departments in several countries and the headquarters is located in Zagreb. They have 270 employees, 70 doctors, 7 surgeons. Overall, Professor Gabrić and his team started 1999 with first implantation of premium IOL. It was the Air Ray at this time, may some of you remember on this lens. Till today, they have done more than 15,000 premium surgeries. They have experience of 1,500 technical eye hands, and they have experience of 1,300 technical synergies. 800 performed by Professor Gabrić himself. They also participated in a synergy study, and today they will do the first implantation of Synergy Toric in their area. So this is a premiere today. Overall to say, Svjetlost Klinik have a huge experience on this. Before I hand over now to Dr. Andreas Reichert, let me thank you to all participants and partners who supported us for such a great event. I wish you and all of us a great live surgery event. And now it's a pleasure to hand over to Andreas. Good luck and thank you.
Thank you very much, Thomas, for this very kind introduction. And welcome everybody. Good afternoon, ladies and gentlemen. And welcome to this unplugged webinar and live surgery event on premium technologies in cataract and refractive surgery. Before we're starting with the program, I would like to address briefly a few details on housekeeping. So first of all of you are put on mute to avoid any interferences with echoes and background noise. Therefore, we would like to ask you to address your questions through the chat function of Zoom that you find in the taskbar in the bottom of your screen. Moreover, we'd like to ask you to respond to the 3 questions on your current surgical routine, usage of presbyopia correcting IOL and treating astigmatism that you're seeing now on your screen. The first question already showed up and we would like to comment on these. For the program of today, we are very happy to cooperate with Svjetlost Eye Clinic in Zagreb. And a special thanks also from my end to Professor Gabrić, the founder and director of Svjetlost, for your great support in this exciting event. In the program, we will learn from firsthand in 4 live surgeries about recent and different innovative technologies in cataract and refractive surgery. This will include, among others, femtoLASIK with the IFS, femtosecond laser-assisted cataract surgery with a catalyst laser system, and innovative intraocular lenses like Technis IANS, Technis Synergy, and the brand new Technis Synergy Toric 2 IOL. For the moderation of today, as Thomas already mentioned, we are very happy to welcome Professor Dekaris and Professor Lazić from Svjetlost Eye Clinic. Professor Dekaris is the medical director and the head of the cornea department. Professor Lazić is the subspecialist for diseases of the posterior segment, and he's the head of the retina department. Both of us will guide us through the live surgery event. They will introduce the patient cases, and they will respond to questions in the breaks between surgeries. Having said this, I think we can expect a really exciting afternoon. And I would now like to hand over to you, Prof. Dekaris, for guiding us through the program. Thank you very much.
Good afternoon, dear ladies and gentlemen. We are very proud and happy talking about whole staff and the whole University I Klinici Svjetlost in Zagreb, Croatia, to share this exciting afternoon with you. We sincerely hope we will provide nice and interesting surgeries, as, of course, premium cataract and refractive surgery, with a small touch of retina surgery as well. So, not to waste your time, please enjoy. We will start with the first case.
And so, on behalf of Professor Gabrić and I Klinici Svjetlost, welcome. It was a beautiful day today in Zagreb. Okay, so the first surgery is going to be performed by Professor Gabrić, and he's going to perform phacoemulsification surgery with implantation of Synergy Toric intraocular lens and Synergy intraocular lens. So it is going to be a bilateral surgery. So let me just show you the demographics of the patient. It is a 58-year-old female. We can go back to the slide with the demographics. It's a 58-year-old female. She's a healthy female. She's working in an office-type job. And her main motivation is to be able to read paperwork and to drive with no glasses. As you can see on her right eye, she has 1.5 astigmatism on axis 115, and on her left eye, she's plus 0.75. Okay, so now we can show you the tests. We normally know the OCT. We will show you the IOL master test, please. You can see the IOL master calculation for the intraocular lens, and here you can see the axis on 118 degrees. There in the right top you can also see the pentacam analysis, which shows astigmatism with the rule, and on the left side, as you can see, there is no much astigmatism. And we normally perform corneal endothelial cell count to both eyes. As you can see, it is very good, over 2,300 cells. On the OCT scan, as it is a premium IOL, it's important that the macula is in a very good position. So we routinely analyze the state of the retina. As you can see, retina is very good. And our surgeon, Professor Gabrić, needs no further introduction. He himself implanted more than 800 Synergy intraocular lenses. So now I'm giving floor to Professor Gabrić. And Professor Gabrić, please, you can start with your surgery.
Hello, everybody. I will start with phaco and first implantation with Synergy Toric.
So Professor Gabrić asked me to comment on behalf of his, because we don't want the patient to be disturbed. As you can see, we marked the axis, and Professor Gabrić, with the cuts on the cornea, already tries to relax the steep curve on cornea. And now, as you can see, we have a very good picture. It's a new microscope, size microscope. And as you can see, Professor Gabrić is using his left hand so that he holds the eye in the position. These are the clear lens patients. So sometimes they have trouble of maintaining fixation because of the Bell phenomenon. They want to lose the fixation of the light. So Professor Gabrić holds the eye with the left hand with the viscoelastic cannula in order to make the eye be still while he's performing it. And now, as you can see, he's performing hydrodissection and hydrodenucleation procedure. His technique is characterized by the way that he wants to subluxate the whole epinucleus and nucleus fragment. Because he wants to perform the phacoemulsification in the pupillary plane. so to avoid the capsular damage and also to avoid the endothelial cell damage. He is now using the Bausch & Lomb Venturi system. Although most of the cataract surgeons prefer peristaltic pump, Professor Gabrić prefers Venturi vacuum pump because it offers immediate vacuum, and so he performs the surgery on vacuum. I think it's 500 milligram. So as you can see, these techniques offer a very small strength and use of ultrasound itself to preserve the cornea, and the strong vacuum actually helped very much to be very, very fast with the surgery and to preserve cornea. Then bimanual irrigation aspiration is very normal for us here. Professor Gabrić doesn't change the settings. He makes the settings actually by pressing the pedal, so he has the maximum vacuum all the time, and so he adjusts the vacuum for irrigation aspiration or for polishing just by his foot switch. It is, of course, very important to clean all the fragments and to polish the capsule, because we want to avoid the formation of posterior lens opacification. We have a very good red reflex. Okay, so after this side, there is some remnants left on the other side, so we want to clean everything. And so the nurse already hands him folded Synergy Toric IOL. First, he puts the viscoelastic in the eye, and then by fixating the eye, he injects Synergy Toric intraocular lens in the eye. It's a beautiful lens with a very nice controlled opening. And you don't need a lens manipulator. You can just start with the irrigation and aspiration to collect the remnants of the viscoelastic and to position the lens. Of course, the marks on the lens must be adjusted with the pre-marked marks on cornea to meet the astigmatism axis. As you can see on the microscope automatically shows the axis. It's a new size microscope that by computer beam marks the axis. So actually we don't need the marks on the cornea, but we did it. So it's a very nice feature from the new size microscope to be able to mark the axis on cornea itself and to show whether there are some toric movements of the eye. After the surgery is done, Professor Gabrić hydrates the wounds, and we usually instill the antibiotic after surgery. So you can see the circles, and it's beautifully placed Synergy Toric lens, both axis-wise and center-wise. So it was an excellent surgery, and it was like 5 minutes. We'll see exactly how much. So it was very fast and very, very successful surgery. After the surgery, we put the soft contact lens so that the patient can see immediately, and so that we don't need to patch the eye for the patient comfort. And this soft contact lens will be removed the next day. Okay. So this was a very nice surgery. Everything went very nice without complication. So I would like to discuss this case with Professor Dekaris. Professor Dekaris, so now as you are also, besides very experienced cataract surgery, you are also a corneal surgeon. Can you tell us why is it standard now to measure the endothelial cell count before every phaco procedure that we do in Svjetlost?
Okay, as spoken before, I'm dealing mostly with the cornea, so I love the cornea, and of course I love cataract surgery. And when we plan something to do in somebody's eye, like in our patients, we want to have at least only one surgery throughout the life to be safe for the rest of the patient's life. Therefore, we can see a very nice clear cornea, have a perfect pentacam, and think about multifocal lenses implantation like Synergy, but we have to be sure that this cornea is able to live long enough to support this lens. So every single patient, be it for refractive purposes or cataract cases, does endothelial cell count, and sometimes we find unexpectedly with the perfectly clear corneas that endothelium is below 2,000, 1,800 or something, or even if the number is very regular, we can see the differences endothelial regarding polymagatism and differences in the endothelial cell sizes. In such patients, we are very cautious because to have all the good properties of the lenses, premium lenses that we have today, we have to have a perfectly stable cornea in a long run.
Okay, so now the question is, if we see that the quality of the endothelial cells is not so good, or if the endothelial cell count is not so good, what can we do? Do we go for the monofocal lens? Do we do some extra precautions during the surgery? What would be your advice?
Well, I don't think it's a 100% certain answer. It depends on the quantity of the cells. If they are under 2,000 or if they are very irregular, then we should be very, very cautious with multifocal lenses. We do have a solution now for, let's say, bad corneas. We also use Johnson Johnson lens called iHance, which is basically structured as monofocal lens. And when implanted with a small myopic shift in a non-dominant eye, we have a very, very good outcome regarding reading vision, even the laptop vision or intermediate distance vision. And we are safe that this type of lens can work forever in a patient eye, even if the cornea shifts toward low endothelial cell count and maybe not such a perfect transparency.
Okay. And if
okay,
we have, for
good news,
yeah, well, oh, they're already so quick.
So you announce the second case.
I'm going to announce the second surgery. So it's the second eye of the first patient. So Professor Gabrić is starting again. As you can see, the paracentesis. So this eye is going to be implanted with Synergy IOL. So there is no toric component because there is no astigmatism. As you can see, a clear cornea cut. Viscoelastic. In normal cases, Professor Dekaris, what viscoelastic do we use?
Well, we need cohesive viscoelastic because it goes slowly out of the eye. It's easy to aspirate at the end of the surgery, and that would be his choice. Perfect.
Right. As you can see, the patient now has a little problem focusing, so that is why it's very important to be holding the eye with the cannula in order to be able to perform perfect capsulorhexis. And the perfect capsulorhexis is also important for the multifocal lenses because they need to be perfectly centrated. And certainly for those patients that have a clear cataract, actually clear lens surgery, the light of the microscopes is a little bit troubling. So that's why it's important to fixate the lens with the cannula. I mean, that's just a suggestion. It's not a must. And also, as you can see, one must be very careful with Venturi pump. As you can see, the strength of the vacuum. And the lens is already gone. So I think the vacuum goes up to 600 milligrams. And in difference with the peristaltic pump, which needs to build up vacuum, the Venturi pump already has the vacuum 600 from the beginning. The machine that we are using is a Bausch & Lomb Stellaris machine. We have such a machine for vitrectomy and also such a machine for anterior segment. I know Professor Gabrić prefers the machine for posterior segment because it has a Venturi pump and very strong vacuum. And as you can see, the polishing is almost over.
So, Ratko, you have mentioned the machine that Professor Gabrić is using now, and I have to mention that we are looking forward with the Johnson Johnson help. We will have a new phaco machine, and it's coming in 2021 called Veritas, very nice, significant name. So we will also test this machine pretty soon.
Well, I hope we will have a chance to show you some live surgery on the Veritas machine. I hope we will be among the first one to get the machine.
Surely will.
Yes. As you can see now, the Synergy lens is unfolding very nicely. The collection of the residual viscoelastic. And so it's a bilateral surgery, so it's almost done. Some surgeons actually hesitate to perform bilateral surgeries. What's your opinion on that?
Well, in our house, most of the surgeries I would say 95% of cases are done bilaterally. The only reason to go one by one is maybe wishes of the patient. Some patients are just afraid to do both eyes. So yeah, this is mostly done.
Okay, so now I've been informed that it was a 4-minute surgery. So not 5 minutes, 4 minutes. I mean, of course, we are not racing with time, but the length of the surgery is important because we want to have as little damage to the cornea and as little disturbance to the vitreous. The hydration of the openings and a perfectly centrated lens. Very nice. Professor Dekaris, do those patients actually already tomorrow can see very well, right?
Oh yeah, most of the patients are very happy next morning. They can see this, they have great distance vision, very good reading distance. So those surgeries are really making happy patients.
Yeah, as you can see, the Professor Gabrić gives periocular triamcinolone.
Yeah, that's a very wise move. We are doing nowadays all the time this. It's a protective measure. It's just one small injection. And in some patients, at least in our region, it happens that patients stop putting drops. They see, oh, I see so well. The doctor gave me drops for 1 month. This is too long. So it's very wise to be sure that the treatment is going to be prolonged during the needed time. And I'm very glad that I see our surgeon coming towards us. So we will be able to pose some questions and hear his answers. Yeah.
Yes.
Okay. Well,
hello, everybody.
Well done, Professor Gabrić. It was a pleasure to see this surgery. Already we have seen it many, many times before, but for you, one novelty, Synergy Toric. Can you tell us how was the lens stability, how you felt implanting the lens, and did you see the marks on the lens?
It's very nice. This is the new cartridge and new folder. It's a similar lenses like the Synergy, but company provide on the haptics rough margin to prevent the rotation in the capsule. There is no problem with this type of lenses when you work the hyperopic hyperopic patient, but if you have the myopic patient, you have the problem because the myopic patient has a big capsula. And if you have implanted these lenses rotated. And we use in those cases multifocal toric from Zeiss. It's a little bit better, it's a little bit less movement in the eye, but it is a more posterior capsule opacification.
Okay, great. Do you think this C loop, because the lens that you have mentioned before, we used to use to prevent rotation of the lens, but this is a small trick with this surface which is not so smooth. Do you expect that this lens is going to be stable and not to move at all?
Former techniques lenses is a stable if you put it on in the position 12 of 6 o'clock, but if you have the oblique astigmatism, you have the problem. I several times to just adjusted toric lenses, and I give up from these lenses and decided to use the different kind of lenses. It's not good for the myopic.
Okay, now let's go. Why did you decide to use toric? Where is the limit or astigmatism limit where you would switch from Synergy to Synergy Toric?
My indication for the toric lenses is more than 1.5 diopters. If I have the less or till the 0.1, I can perform the limbal incision, and I will show you here. For example, I don't see, do you see? When you perform, this is the cornea, when you perform incision on the steepest meridian, if you go inside, you decrease for 0.75, always operated on steepest meridian. If I have minus 0.5, I perform on the opposite side, also incision, and perform this type of surgery. If I have more than 0.5, I perform limbal incision, more than two-thirds of the limbal relaxation. On this position and this position, and I can solve the problem with more than 2 diopters. But if you have to perform the limbal incision, real posterior incision, you induce 0.25. If you perform the limbal incision, you perform 0.5. If you perform clear cornea, you can decrease the number of 0.75. That's useful. That's my normogram. If I have the against the rule, I do the surgery on the temporal approach, and also I do the 2 incision on both sides, and also I can perform the limbal relaxing incision if I don't have the real proper lenses. That's very useful for beginner.
Okay, and I would like to ask you about the Venturi pump, since I like the Venturi. So usually cataract surgeons don't prefer Venturi pump. Why do you prefer Venturi pump?
I prefer the Venturi pump. It's my character. It's a very fast surgery. First surgery take 5 minutes and 20 seconds, and second surgery take the 4 minutes and half. I prefer because it's a automatic operating, automatic the cleaning. I will not change any my parameters during the any part of the
even during the polishing. Yes, even during the polishing, you just control the vacuum.
I control by my foot.
Okay, and what about the triamcinolone periocular to prevent cystoid macular edema, to prevent cornea?
I saw that is many of my patients has the problem with drops. For example, when I operated Ivana Trump, It's wonderful surgery, but have the problem because he didn't want to didn't want to put drops in the eye. Why? Because it will be spoil makeup. And I always use triamcinolone to protect the posterior segment from the people who are not able to apply drop himself or themselves, and that's less cystoid macular edema.
Yes, because we are not that concerned about the infection and antibiotics. It's the problem that they don't put the corticosteroid eye drops and they can develop the cystoid macular edema. Absolutely. Yes. And what about holding the eye with the viscoelastic cannula while operating?
The main problem when I was operated, I have two operations. 13 years ago, I had the LASIK in Köln. Dr. Maus performed the LASIK by concerto. And 10 years, I was excellent, and I leave this minus 0.5 diopters to provide for me the near vision. 3 years ago, I had a small cataract diabetic opacification. And our colleague from Belgrade, previously our employee, Dr. Cerovic, operated my right eye. And I get it the symphony. And several months ago, Ratko performed for me clear lens extraction, and they put it the Synergy. I think only guy in the eye surgeon who has the two premium lenses. When you ask yourself, what did you do for yourself? You will do always the best. And I decided, because I tried all the multifocal lenses in a whole the world, to put the symphony. And I'm very satisfied. I can see without any problem 10-0 nylon suture, without the microscope. From time to time, I operated outside of the Zagreb strabismus screen surgery. I have no problem to make the suturing without the spectacles, without the microscope. It's easier for me.
And so now, after you had the
they
lenses,
call me in a second theater, second operation. I will do the femto-assisted cataract surgery. It's for the patient who has no flux, femtosecond, and now I will show how it do on the femtosecond laser.
Okay. Okay, so let's go and introduce our next patient. So it's going to be femtosecond laser-assisted cataract surgery with the implantation of Synergy lenses. Of course, Professor Gabrić will perform the surgery, and Dr. Ivan Gabrić will perform the surgery. Dr. Ivan Gabrić will perform the femtosecond laser surgery on new Johnson Johnson laser catalyst, right? And as you can see, it is a 60-year-old male. He is a very healthy male. He is a manager. He drives a lot during the night. He is highly motivated to be able to read in all conditions. As you can see on his right eye, he has plus 0.5 cylinder on axis 100. And Ivan Gabrić is going to perform the first surgery, the catalyst surgery. Okay, now we can see the data for the patient. As you can see, this is the astigmatism with the rule. It's going to be the implantation of the toric IOL on 92 degrees. As you can see, again, the endothelial cell count, the pentacam analysis, which is very important before the selection of the patients. And now let's go. Okay, so this is the left eye. Okay, and now, as you can see on the left eye, there is also the astigmatism with the rule. And so now we are going to join Dr. Ivan Gabrić in the operating theater number 1, and he's going to comment on the catalyst procedure. Ivan?
Hello, everyone, and thank you for joining us today. Today we will be performing bilateral femtocataract surgery. Our patient is great, and the specificity today is that we're going to use the new Catalyst software version 6. This is the rollout, and there are some new features like the toric markers we will demonstrate during this surgery. I will now begin with the vacuum. Budite mi dobri, savršeno gledate. Može BSS. So the patient is very compliant. We are now doing the liquid optic interface. One of the very special parts about the Catalyst is the fact that there is no blackout during surgery. So unlike other femtocataract platforms and other femtolasers, the vacuum power of the Catalyst is such that it will not cause any blackout. Now we're doing the capture part. The capture is great. The Catalyst also has a very specific function where it allows us to lock the bed, so it moves the bed constantly to alleviate any movement of the eye of the patient. This is, for me, it's an amazing technology. Now the OCT part is going on. We see the posterior and anterior part of the cornea. We see the posterior and anterior part of the lens. And we are now getting the areas that we can do surgery on. The device is now allowing me to make just a slight adjustment on the cyclotorsion. And now, since we are approving this, we can proceed. One of the new things that the machine is doing for us is it is allowing us to make manual edits here for the toric markers. They have increased the speed, and now we're starting the procedure. We're now at 1 minute and 37 of vacuum time. The pattern that we are using is for clear lenses. It involves a hexagonal shape, and it's kind of like there's softening of the nucleus, and there are 6 separate parts. The capsular rhexis is 6 millimeters, and it was completed in about 1 second. And another very, very, very important fact for femto machines. And this patient now, the first eye has been completed. And we are now going to change eyes. Okay, so my assistant will take the patient out while I am changing the vacuum pump. Some surgeons prefer to work with more than one operator on the Catalyst. I personally find it's easiest for me to work alone because I'm in full control of my procedure. My colleague is now putting in anesthetic drops, and he is going to put the speculum so the eye is more stable. Now I'm scanning the procedure pack for the machine, and the left eye is confirmed. As you can see, this was done very, very quickly. And let me just talk to the patient for 1 minute just to make sure that he understands what we need. Molim vas, samo gledajte mirno, molim vas, samo sekundu. Odlični ste. I sometimes use the pedal on the floor to achieve vacuum, and sometimes I use the button on the control panel. There is no real rule. It all depends on where's the nearest thing for me. As you can see, my patient is amazing. And now the docking process is going on. Another very nice thing about the Catalyst is the liquid patient interface. Liquid optics, it's just a lot nicer for both the surgeon and the patient. The machine is now locked, the fluids have been confirmed, and we are now again going into internal guidance mode. The OCT is doing its thing. While the OCT is working, the Catalyst also registers the 3 little dots to align itself with the pre-applied toric markers. They've added a link to Cassini, which is a keratometry device, which unfortunately wasn't yet available for us to try. And so in Catalyst version software 6, it's even available so you can have cyclotorsion control from the machine. Now I'm making a slight adjustment on where the toric markers are being made, just so that they fit. and the machine is starting. We are now at 1 minute and 25 of vacuum and another 20 seconds remaining. So both eyes will be done in less than 2 minutes of vacuum time. I know that there are some horror stories about cataract surgery using a femtosecond laser and that it's slower or it's something, but if you have a good team, if you know how to use the device, you can be very quick. 1 second remaining, toric markers being done, and that's it. We are done with the femtocataract part. Now the patient will be moved from bed of the catalyst to the bed for lens implantation. And I will be joining Professor Dekaris and Professor Lazić to discuss a little bit about the catalyst.
Okay, Ivan, can you hear me?
I can hear you.
So, what's about the catalyst that it's better than the previous femtosecond laser you worked on?
Well, the catalyst is the first femtosecond laser that I used for cataracts. But I use other femtolasers in my daily routine for femtoLASIK surgery. And the experience of using a femtolaser for LASIK has helped me to achieve a smooth docking process. Because once you learn how to dock a patient on the femtoLASIK machine, you know how to dock it on the femtocataract machine. The difference here is with the integrated vacuum pump, with the liquid optic interface, with no blackout for the patient doesn't have a blackout from the suction from the catalyst. They are
Why? Because there is less vacuum?
There is less vacuum and it's softer vacuum around the lens. Most femtolasers for LASIK and for cataract surgery are making blackouts. And the blackout scares the patient. Then the patient is very, very concerned because it's all dark and it's long, it's taking a lot of time, so they get scared. The difference with a catalyst is they see through the entire process, and it's so quick.
And of course, the safety feature, it's very important not to deform the vitreous body, right?
Exactly. Now, you're a retinologist, so you care about that, and Professor Dekaris is a cornea specialist, will care about almost no force of applanation to the cornea, because there's a liquid between the eye and the machine, so it's working through a balanced salt solution, so it's very, very good.
So we had a little timer there showing that you perform both procedures in 5 minutes, right?
I didn't see the timer because I was...
So what is your advice or message to those that think that the workflow of the whole procedure will be slowed down?
You can see now they've switched the patient over, they're draping the patient, and they're beginning the lens extraction. If you have a good team, and if you have a device which is good and quick, there are some devices on the market that claim to help, but they're not as quick. They're not as good. One of the things is some surgeons like the catalyst just for capsulorhexis, because it does a capsulorhexis in 1 second. Just imagine. It's very good, especially in very hard cataract cases.
Yes, that's what I wanted to ask you. Does it help to soften the... Have you tried mature cataracts?
We've tried big white ones like Moby Dick's, literally. Super white, so big you couldn't even measure without an A probe. And it's really been a big help. Not so much in premium surgery because they usually do clear lens and refractive lens, but for heavier cases, the catalyst has been great.
Okay, great. So Professor Gabrić is already ready to finish the job, right? So Professor Gabrić, please start your surgery.
Daj mi viskoelastik. Ne vidim, okreni prema meni to.
Još malo.
Sad ću ga podesit.
Iglica.
Ne treba, daj mi pincetu. I just to remove capsule. It's a wonderful capsulorhexis.
You need to center the microscope.
Voli mi po rožnici.
Vedrane, dajte im recite da... Ne, sve je okej, nego ne čujem baš dobro Gabrića. Yes. So this lens, after it's been softened by femtosecond laser, looks like a snowflake. And I mean, it's even faster than when just vacuum-emulsification is performed. So it just does the suction. As you can see, the irrigation and aspiration is also quicker and easier to perform, because the femtosecond laser facilitated the separation of nuclear material from capsule as well. And we can see the perfect capsular axis. In the right top corner, you can see it's 2.30 minutes. I was actually a little bit skeptical about femtosecond laser-assisted cataract surgery, but I think it's very, very fast. As you can see, you can perform your cataract in like less than 10 minutes using both femtosecond laser and vacuum emulsification. And of course, we are implanting Synergy Toric IOL. So it's going to be 90 degrees axis. And not to mention how cornea appreciates the assistance by a femtosecond laser. Yes. And of course, we need to always have in mind that the longer the manipulation on the anterior segment, the more inflammation that can cause cystoid macular edema. So it's very important to be quick and efficient in the anterior segment in order to also prevent the possible complications as a capsular rupture, which is less common with the femtosecond laser-assisted surgery. And of course, as Ivan mentioned, the softening of mature hard cataracts, so softening them by femtosecond laser prior to vacuum emulsification also decreases risk of possible nucleus drop or corneal edema. So again, soft contact lens, so we want the patient to see immediately. We explained to them that it's going to be a little bit blurry.
Gotovo, gospodine?
So as you can see, 4 minutes and 20 seconds. And when we include the 2.5 minutes, so it's like 6-7 minutes per eye, both laser surgery and vacuum emulsification surgery. Very good. Professor Dekaris.
Okay.
So what do you think? So what do you think about the femtosecond laser becoming a standard of care in cataract surgery?
Well, me, like you, was a little bit skeptic that it comes with the age, but definitely I was always thinking, oh, this will slow down the program, and our patients are used to come to our clinic and that we are very quick and effective, and they are in and out in less than 2 hours altogether. So this was a concern at the beginning, but we have seen today that if the machine is situated close to the phaco machine, and if we can switch the patient from one bed to another in a short time frame, the fax itself does not take too much time. So now I think it's a good solution. It's a very expensive solution also, so in a real life we have to have also this in mind. So it's nice to have, But of course, in some smaller institutions, it's maybe not so profitable to have it, to buy it.
And so what do you think is the most benefit? Is it like a perfect capsulorhexis, perfect cut on cornea, or the softening of nucleus? What do you think?
Well, I think all three that you have mentioned. And one factor that does not have to do with the surgery at all is the psychology of our patients. Generally, among patients, there is opinion when something is done with a laser, that must be so perfect, so precise. So some patients really actively try and ask us whether we can do the laser surgery. And in a way, they are satisfied with the surgery even before the surgery, because they really believe in such a machine. So this is one psychological factor. And we know that patients with multifocal lenses, sometimes they can complain. They are a little bit clear lens patients, can be very demanding. So if they start the surgery thinking that the surgery is done in the best possible way with the most modern equipment, they will feel better even after the surgery.
Okay.
Okay.
As I can see, Professor Gabrić is ready to finish the job. You see, it's interesting that the femtosecond laser procedures can be, on patients that have bilateral surgeries, can be performed on both eyes prior to surgery. So actually, it's very efficient. Can you please centrate the microscope picture a little bit? Yes, that's very good. I mean, doesn't this remind you like a snowflake?
Yeah, it looks nice. It really looks pretty nice. And we can see the work of the laser very well.
Yeah, this is really such a perfect structure that only a laser can do, right?
You see, now he held the eye with a knife also.
Yes.
Paracentesis, not to waste time by changing instruments. So this was in his hands, so he just keep the eye steady with the paracentesis knife.
Yes. Fortunately, it wasn't with the sharp part of the knife, but good. And so now he's performing hydrodissection, right? But also the hydrodissection is facilitated by the femtosecond laser, right?
Yeah.
Am I right?
Yeah, and you can see how it's done very quickly and efficiently. And Professor Gabrić likes to have the nucleus at the level of the pupil, not in the anterior chamber itself, not to be too close to the cornea, but at the pupillary level, it's very nice to have a nucleus. You do not really have any stress on the zonules. So when you work inside the capsule, you do have a stress on zonules, and in lenses like multifocal lenses or toric lenses, we should really be very, very careful that the capsule itself and zonules which holds the capsule are stable and not damaged in any way. So his choice to do the surgery, the main part of phacosurgery at the level of the pupil, is very wise. The zonules are really not shaking at all during the surgery.
Would you agree that the trend now is to, I mean, before I know it was like more in the bag surgery.
Yes.
Is it today the modern trend now to actually lift the process of phacoemulsification a little bit higher into the level of the pupil?
Well, looking at the very many live surgeries around the world, we can still see, I would say that maybe most of the surgeons are still working in the bag. But with the lenses, premium lenses coming on, toric lenses, and those lenses which really need perfect centration, I think this approach that he's using to do the phacosurgery at the level of the pupil is safer regarding stability of the lens, because you do not shake the zonules at all.
Yeah.
So maybe we should also point out that, I don't know whether you see it on the screen, no phaco energy was used. So it was just a phaco probe without phaco energy.
Just aspiration, right?
Yeah, that's what they told me from the operating theater. Maybe if we can
maybe we can show on the screen with the Maybe camera can have us the screenshot of the machine. That would be nice.
Of course, doing phaco without any ultrasound energy is very, very safe for the cornea as well. So if the lens is not thick and one can do it with an ultrasound probe, but with a minimal amount of ultrasound power, that's a wonderful surgery.
Yes, and what about, for example, if a complication occurs like a posterior capsule rupture, do you think that we should switch to monofocal, or is it still okay to implant the multifocal lens on the bag?
You did have to pose this question,
well,
because most of the surgeons would say it's better to switch to monofocal.
Look, the vacuum is 550.
Yeah, or extended depth of focus lens. However, professor's choice would be to still implant multifocal lens. Of course, this depends on the measure of the problem. If we have a small opening and the capsule is still safe, you can even put it in the bag. So it really depends on the amount of the problem, not just black and white answer.
Sure, because if you have a small rupture on the posterior capsule, it's
no
like
problem.
you perform JAG laser already.
Exactly.
Yes. So the surgery is done, right? Okay. So I just wanted to mention that the laser also makes the toric markers so that you know where the axis of the lens should be. So it's interesting. I mean, we did dye them, but the laser itself also marks on cornea where the lens is supposed to be. Vedran, am I right? Okay, good. And the eye drops, and the surgery is done. So again, triamcinolone, right?
Yeah.
Oh, the soft contact lens, yes.
Meanwhile, we can answer one question from the audience. It was shifted to us that there was a question, why did we put, or why did Professor put a contact lens after second surgery, meant the previous case, the previous patient. So we do not patch the eye. If we are doing bilateral surgery, neither of the two eyes is patched. The patient goes home with two contact lenses on the surface, so he or she can immediately see well and use multifocal lenses and get to use to them. And on top of that, the incision point is also does not feel protected. So next day, the lenses are removed. So this was the question from the audience, and Professor have joined us now.
Okay. So how was it?
Perfect. Less than 25 minutes for 2 femtophaco. It's excellent result. I can do 10 cases if I work on one bed with normal surgery. If I do on the 2 beds in 2 operating theaters, I can do 12 operations. The femtosecond laser is a great equipment for the young doctor, but for me, it's a little bit a waste of time because I'm very fast. And I today try to operate slower than normal. But for young person, like my sons, like my assistants, is a wonderful thing because they short the length of curving.
Right.
This is, apologize, Ratko, nice question from the audience, so we will be polite to them as well.
Sure.
And it fits well in the story. So the question was, which skills are important to finish surgery in just 4 minutes? So why do you finish so quick?
I want to show the people that possible that we can do it on the ordinary patient. But I have to tell you that I operated one of the best surgeons in the split, Dr. Julian. He's guy who operated everyday cataract. He has the Synergy both eyes. I operated the main cardiosurgeon who performed more than 50 heart transplantation. He operated every day. I operated, samo čas. I operated the main neurosurgeon in Croatia who is every day operating his brain of the people. For the operation is not so important how quick you operate it. It's most important that you learn every steps, and I insisted on my assistant to adopt it, to achieve the level of the technique. It's very important. I don't use, you will see many instruments. I don't need the forceps for the capsulorhexis. I don't need the chopper. I don't need any other instruments. I don't need to put it the intraocular cameral lidocaine. It's possible to achieve the technique if you have the good teacher, and you have to exercise. For everything in the life you need 10,000 hours to be the master. If you want to be the master in another field, you need another 10,000 hours.
So the femtosecond laser softened the nucleus. You didn't actually use the ultrasound, right?
Okay, I didn't use the femtosecond, but it is not the point of view. That's important. That is, femtosecond laser is a very useful device for young doctors, because they need a lot of time to spend in the operating theater to achieve this technique that they can remove these lenses from the capsule. I developed the technique for young doctors how to operate this type of cases. I teach my doctors on the multifocal lenses, but from the back of the operation. I don't need to, it's not necessary to need the doctors with cataract or 75 years. It's easier to make. I perform 3 waves. First wave pass between the capsula and epinucleus. Second wave of the fluid lift up the nucleus up, and third wave of the liquid, the luxated the nucleus in the front of part of pupil. And you need just to perform only aspiration. And from time to time, maybe to perform a few phaco steps. It's more easier to learn the people on this way than they gave them to grooving, rotated, and they are not skilled. And they make the rupture of the capsule, they make the dislocation, they drop the nucleus. It's a hard way to teach people.
And how difficult is it for experienced phacosurgeon to learn femtosecond laser-assisted cataract surgery?
That's very important. It's a hydrodissection is very important. If you put it between the fluid between the epinucleus and hydrodissection, you will leave 50 microns of the epinucleus stitch for the capsula. And that's the problem for the many young person to remove this part of nucleus, because when you apply the femtosecond laser, the 50 microns leave it in the capsula. If you remove it between the capsula, and that's the special procedure to put it the direction of the water throughout the capsula, you will remove this part and you will finish like me.
Do we have any other questions for Professor Gabrić?
Yes, so we can proceed. If they are ready for the surgery, we have a discussion afterwards. We have many more questions.
Are we ready for the next surgery?
That's what yeah.
Let's check with our...
Okay, this was already, I think we have a questions from the audience. From which level of corneal astigmatism of the steep axis do you prefer Synergy Toric? But I think you already answered this question. So Synergy Toric is going to be used from astigmatism of which diopter up, in your view?
I can do without the toric lens is still 1.5.
Okay, we have. Okay.
But more than the 1.5, 2.2, 3 or more astigmatism, I will always use the multifocal toric lens.
Okay, now it's clear. So you double said it. Okay, we can move forward. So now we switch to the refractive case on the cornea. This is going to be performed by my colleague, Dr. Maja Bohač. And she's going to perform femtosecond LASIK using Johnson Johnson femtolaser and the ablation part with the Schwind 1050 eczema laser. And here are some data about our doctor and about the patient who is going to be operated. You can see the main data. It's a young, healthy woman. Previously, she wore contact lenses, and she complains of poor night vision even with the lenses. And the refractive error that she is going to treat is on the slide. We can move further. So here we have seen the preoperative exams of the patient you are going to see during the surgery. On the left side, you can see pupillography, and in scotopic conditions, this patient has a little bit large pupil of 7.5. And on the right side, you have a pentacam view of the corneal topography, playing with the rule astigmatism, so nothing special or nothing which would make refractive surgery not easy to perform. Here you see two more exams which are made pre-op. So you can see the Barrin-Ambrosio analysis for ectasis risk. So always we do this to be sure not to put the cornea in the risk. And on the right side, you can see aberrometry with Zernike aberration pyramid. So these are preoperative data, and this is the ablation plan for Amaris. The analysis is ocular wavefront analysis, and the surgeon, Dr. Maja Bohač, is going to show you the surgery itself now. Please, Maja, you can start.
Good afternoon, ladies and gentlemen. I will perform femtolasic on the young lady with myopia and myopic astigmatism. I will do ocular wavefront femtolasic. So we will start with the femtolaser of both eyes. I am attaching the vacuum ring on the cornea, and I am orientating myself around the limbus. Može? Now we are applying the vacuum. The patient will lose a little bit of light. Now I have to adjust the head so I don't touch the eye or supraorbital arch. Malo dole bradu prema prsima i glavu ovako srećice. Super si. Okay, and now I am putting the femtolaser PI inside the eye. I have to center it over the pupil, in center of the pupil. Okay, this is perfect, and now we need 18 seconds to make the flap. This is one of few femtolasers that we use in our clinic. It's not the gentlest femtolaser we have, but it's one of the best because due to the higher vacuum levels on the eye, we have a much more surgeon control over the patient who is not compliant. So we can control a little bit of eye movements, and we can perform around 99.9% of patients on the vacuum. In comparison to other platforms with whom it's not possible, either due to too small vacuum, so the patients are detaching from the PIs, or because of the size of PIs that cannot fit in the eyes in our area, because the majority of our patients have pronounced either noses or eyebrows. Malo još anestetika sreće. Okay, we did the left eye flap. Now we are going to do the flap on the right eye. We are using either 90 micrometers or 100 micrometers flap. The intralace has a 10 micrometers deviation, so when we aim 100, we usually get something in between 100 and 110, which is really nice. Opet mi obje okice otvoriš srećice, fantastična si, bravo Ljube. I pogledaš mi opet u centar bijelih svjetala. Okay, the other eye. I'm trying to have the equal amount of sclera on the lower and the upper part of the eye in all four quadrants, so I can easily put the ring, and leaving a little bit white more in the upper part. Može? Dobar. I'm leaving a little bit whitish in the upper part because patients have Bell's phenomena, and all of them move a little bit after we press the vacuum. Super si srećici, idem te stisnit. Okay, now I'm putting the PI inside, in the center of the pupil. Great. 18 seconds to go. The laser has a raster pattern, and it's leaving the excessive amount of air and bubbles in the pocket, which is near the hinge, the whitish part that you see. It usually doesn't affect the eye tracking, just from time to time. And we made both flaps. Bravo, najteži dio iza tebe, još 5 minuta da skinemo dioptriju, to. Now we are moving to the excimer laser. We work with the Schwind company for the past 10 years. Now they have the fastest laser in the world. We are working with 1050 laser, which is a great new machine. It needs 1.5 seconds for 1 diopter. You see a little bit whitish on the flap. Vidiš zelenu točkicu? Sad mi lijepo gledaš u tu zelenu točkicu. Nice edges. We took a 9 mm flap with a 3 mm hinge. We can discuss the size of the hinge. It would be better maybe to take a little bit bigger, wider hinge, so we preserve some corneal nerves. But with this small hinge, I get a better ablation on hyperopia and high astigmatism, because I just have a little bit more space on corneal bed. Now we are taking the Scc measurement, so we are measuring static cyclotorsion. And after the static, the laser is compensating, just malo mi samo u desno, srećice, malo u desno, super. After the static cyclotorsion, the laser by itself is compensated for the dynamic cyclotorsion. For this patient, for these patients with 0.75 seal, it's not so important. But when we go to the higher correction of astigmatism, static and dynamic cyclotorsions are really important. Super si srećice. Now we will lift really thin and nice flap, and you can see nice smooth corneal bed with just a little bit OBL over the pocket. Savršeno ti je oko. Ok, I now have to take this. Upala sam ti crveno da oni vide kako radi laser. And now the laser will perform for 17 seconds. This patient has quite large pupils, 7.4 millimeters, so we decided to use 7.2 millimeters optical zone with total ablation zone of 8.5. And we use ocular wavefront, although we have a virgin eye, so amount of aberration is not really high, especially for the right eye, but taking the small irregularities out of the eye will enhance the quality of patient's vision during the nighttime, during the mesopic and scotopic conditions. For these thin flaps, it's really important to take all the water out underneath the flap and leave everything dry, because they are more prone to stria than in comparison to thicker flaps of microkeratom. But after you get used to it, it's getting better and better. At this point of time, probably 70% of our surgeries are femtoLASIK. We almost don't do microkeratom anymore. It's a quicker surgery. We could do 2 eyes microkeratom in around 6 minutes, and the best results that we can get with the femtosecond is around 10 to 11 minutes. However, speed is not always the best option that we want, so we sacrifice some minutes to get the better patient results. Patients feel more comfortable under the laser because they have a feeling that everything is done with the laser, and we don't have complications on the flap anymore. And it doesn't matter how good of a surgeon you are, there is just a statistics on the microkeratom. It's not very often, But it happens that you get buttonholes, Bowman strips, incomplete and irregular flaps. And with the femtolaser, you always have an option of redock if you have a vacuum loss, or simply stop the surgery and do PRKA around a month and a half or 2 months later. And you don't have a cornea, if you don't lift the flap, the cornea is not, it's also cut, but it's not cut in that wave like with the microkeratom. Super si srećice. Pogledaš mi u crveno. Okay, for the left eye, which was done first under the femtolaser, you can see that there is almost no OBL anymore. Savršena. Nižni flap, u zeleno mi gledaš, ljubice. Super si. You can see the nice clean edge. Personally, I don't like high energies on the flap because I think they're putting more energy to the cornea, which can cause inflammation. However, you have a nice option with intralaser to choose the quality of dissection you personally want to have, and to either increase energy to have a easier dissection, or to decrease an energy a little bit to have a harder dissection but less total energy to the eye. Malo mi dođe desno ramenima, cijela malo desno. Super si srećice. Okay, we are doing the cyclotorsion once again. Okay, the laser showed it was more than 5 degrees and we want it less so that the ablation is precise. Now we have 0.5. Again, nice and smooth corneal bed. It looks really nice. Mutno je srećice, sve je super. Nice and dry, but just in the case. And now you can see the laser ablation. This laser has the smallest spot size of 0.56, and it has a thermal control. So every laser pulse is put in a different place so we don't hit the cornea. For LASIK and ablations of 16 seconds, it's not so important. But when you do trans-PRK, when you're taking the epithelium off in the same act, then it's very important to not overheat the cornea. Either you will get the inflammation tomorrow morning. So with this laser, we have a white eyes tomorrow morning because of the thermal control, and we don't have to stop the ablation from the beginning till the end, even if it lasts for a minute. Jako si dobra, ljubavi. Bravo. To be completely sure that you reposition your flap nicely and that you don't have an excess water underneath the flap, you should look to the silver edge around the flap, which is this one, and the gap should be the same all over the cut, which here is. Bravo, srećice. And we are done. Bravo, ljubavi. Biće ti sad mutno kad se ustane, što je potpuno normalno. Pogledat ćete moja kolegica, zato što ja moram ići gore, ovo traje još 45 minuta, nas dvije se vidimo sutra oko 9. Može? Bravo, super si bila. Svaka čast. Bravo, srećice.
Bye to the patient, and we're going to take a little statement from her right now.
Okay.
Let's just get set up here, but let's first get the patient out.
Okay, we can do it this
Okay,
way.
so Dr. Bohač, very nice, 11 minutes.
Thank you.
Very good, and since you've already talked about most of the pros and cons of the IFS, one thing that I would like for you to address is, and for the audience, you know, you have experience, and we as a clinic have experience with multiple femtolasers, and you've created flaps on the Femto LDV, Da Vinci from Zimmer. You've done it on the IFS. on the Visumax, even on the intracore from Bausch and Lomb back in the day, and now with the Schwind Atos. And you've already said the differences between the platforms, but in general, what do you feel is the most important part when making a femtolaser? What's the most important part for workflow?
Depends. It actually depends from the patient to patient. Every laser has its pros and cons. One thing that you want is nice and easy dissection. So you want to dissect the flap easily so you don't have a tissue bridges. Because when you have a novice surgeon, they will struggle and they will make a complication on flap. That's one thing that is important. The other thing that is important, and it is important for this area with the big noses and pronounced eyebrows, is the size of the PI. So from time to time, I want to have a small PI, I want to have a high vacuum like Intralase. So I would say Intralase is an excellent everyday machine that you are sure that you will finish the surgery on it. Okay. But there is also another part of the story. From time to time on blue eyes, on the eyes with the bad tear film, the eyes prone to inflammation. I would like to have a laser which is having even lower energy, so I don't see the edges, and I will struggle with the tissue bridges a little bit just to have a low energy on some particular patient.
Okay. And the other question is, you've mentioned we don't do microkeratums anymore, almost none. But when you compare the types of refractive surgery on the cornea we do now, we do PRK and trans-PRK, we do microkeratom LASIK, not often, but we are able to do it. We do femtoLASIK, and we have done lenticular extraction.
Yes, we started in 2012 with a SMILE, which gave us great and promising results. However, it has a very narrow range of refraction that we could treat, and was struggling with astigmatism in those times. Okay. Now we have a different option from the Schwind company. We are using the SmartSight lenticular extraction. They improved some previous problems of SMILE, of size. So now we have a cyclotorsion control that we can treat astigmatism. And in my opinion, although I love microkeratom because that was my start, lenticular extraction is the surgery of the future. Now we are using it for a dry eye patient, for a higher refraction, but you have a patient that you don't have to worry about the day after, because there is no flaps, there is no stria, there is no dislocated flaps, and there is no prolonged dry eye. So it has its place, it's here to stay, and maybe the ratio of 70% femtolasing and 30% everything else will change to be more lenticular extraction. And there is always PRK for thin corneas, very young patients, and of course for therapeutic reasons.
Okay, great. I think that Professor Lazić has already started his vitreoretinal case, and we will now go and join the others for a small discussion. Thank you.
Okay, now Professor Ratimir Lazić has already started the surgery, because retinal surgery can't be done in 4 minutes. So I will just shortly introduce the case that he has already started to work on. So Professor Lazić is going to perform surgery for the macular hole, grade 4. And together with the retinal surgery, he is going to remove the cataract and implant eye-enhanced lens, which is the extended depth of vision type of lens. We have seen data about the surgeon and small data about our patient. It's a female patient, age is mentioned, and the vision, which is pretty poor on the right side, is also mentioned on the slide. And next slide, we will see the macula, the OCT of her macula with the macular hole grade 4. So the data about the patient we have seen. We will switch to the surgery. Ratko, please, you can start your comments, and you will perform your surgery in a completely novel way. So you will use digital microscope from Zeiss, which is called Artevo i800, and you will not observe the surgery through your microscope in a conventional manner, but you are wearing those fancy white glasses, and you will do the surgery observing the huge screen in front of you in a 3D way. So please comment also What is the benefit of such a surgery and such a new technology? Please go ahead.
Okay, I hope you can hear me. Hello, everybody, again. So, as you can see, I'm operating on new Arteva size microscope. Of course, the Ingenuity technology is already present for several years now, but this Ingenuity product from the other company, you have to mount on your existing microscope. And the size microscope is the first original microscope that is designed only for the 3D surgery. So it's the complete optics are adjusted to 3D surgery, and I don't know whether you can see, but I'm showing you right now. I can show you right now. Do you see it now? I'm actually not using, no, not this one. You have to point the camera to me. To me. I'm showing that there are no oculars. There are just oculars that I'm not using. Can you see it? And there are no oculars for the assistant. Ante, is it visible? So you see, I'm just observing on the screen, and this microscope already has only one oculars for the surgeon if somebody needs to see something, but I don't see the point. So I'm already in the eye. We can switch back to the picture from the microscope. As you see, I'm already in the eye. I stained the vitreous with the triamcinolone. I induced the posterior vitreous detachment, so it was a macular hole grade of 3. And as you can see, there is a hole, and I dyed the ILM, and I just, with finesse loop, started the peeling. But now, for the interest of our meeting, I'm switching back to the anterior segment. So as you can see, there is some cataract. I mean, it's not like a cataract that needs to be done, but when we do these procedures, we do the combined procedures. We want to do the cataract surgery and the vitrectomy in one procedure to just spare the patient of extra stress of doing both surgeries at a different time. So as you can see, the cataract surgery can also very nicely be performed on the 3D technology. So usually the 3D technology is associated with the vitrectomy surgery, but I encourage you to try the cataract surgery on the 3D technology as well, because you have a very great sense of depth, and I can appreciate capsula very, very nicely with the 3D view.
Professor Lazić is now performing the capsulorhexis, again using only the view from the monitor. His hands are just with instruments, and the oculars are pointing up. While we're looking at him working here, I hope that he will allow us to showcase the OCT of the Arteva microscope at some point when we go back into the vitreous.
Yes, because this microscope has an intraocular OCT.
Okay, and Professor Lazić, when you perform cataract surgery for vitreoretinal patients, what kind of lenses do you use?
Well, you know, before we were very conservative, and we actually said, well, there is no place for any premium IOLs in patients that have vitreoretinal surgery and combined. But now with the eye-hands technology, so this extended depth range lenses, I'm very comfortable of implanting the eye-hands Johnson Johnson lens for the patients that also have macular pathology, because they actually act as a monofocal lenses, and they also offer some intermediate vision to my patients. So I'm actually very comfortable of implanting the eye-hands lens as well, not only monofocal lenses for the combined patients.
And when using the 3D vision system, you've already said how great it is for the posterior segment, but how do you feel using it for the anterior segment?
Well, you know, I love it. Sometimes when I just have cataract surgeries to perform, my staff already knows that I want a 3D setup. I mean, they would rather prefer me performing the cataract surgery in normal setup because it's some extra work to do, but I just love it, and so I perform it with the 3D technology because it really gives me a great sense of depth. So I'm actually very sure where I actually am.
And the whole staff here, your surgical staff, is using 3D glasses. That's so that they can see what you're doing.
Yes, you know, 3D glasses are excellent because the novice surgeons can also enjoy and appreciate what I'm doing. They don't need to look through the microscope. So that's very good. As you can see now, the cataract surgery is a little bit different because when I'm doing the vitrectomy, I already vitrectomized the eye. So it's for me, it's, you know, you have a very deep anterior chamber. And that's why you need to be very careful when performing phaco in vitrectomized eyes.
And now the eye-hands is going in. It's a one-piece IOL.
Yes.
Usually you used to do three-piece IOLs?
Well, yes, but you know, as you can see in this particular patient, since I already performed vitrectomy, I would feel more comfortable since I'm not quite sure about the integrity of the posterior capsule. I would be more sure if I place the lens on the back. Mm-hmm. But this doesn't make any difference as far as the eye-hands lens is concerned. So the one-piece lens offers great stability for patients also that have a vitrectomy. Okay, so now we'll go back to the, let me just give me some methyl cellulose for the anterior chamber. So I will just put some for the anterior chamber, please. Yes. I want to stabilize the anterior chamber, yes. Okay.
Okay. And now you're going to allow us a short view of the OCT system.
Yes.
Okay, great. And how has that helped you?
Well, I mean, I'm still, okay, now we need to switch to the...
The OCT is now being switched on?
Yes, the OCT has been switched on.
Okay, let me just get the depth.
Okay, we need to reset the microscope here. Yes, okay.
Okay.
Okay, so with this new system, we can actually also sharpen the picture with the biome.
Oh, okay.
With the switch, okay. So now,
so now we're getting the macula.
We're getting the macula, and now I'm positioning the macula.
Okay, we're getting a good image here.
Yes.
Wow, this is almost diagnostic quality images.
Yes, so now you can appreciate there is a macular hole there. But let's try. Okay, so let's see. But you see, the macular hole is already. You can see on the bottom there, the macular hole. But you see, it's already a little bit closed because I performed vitrectomy.
Okay, and
so as you can see, now you can see that there is a macular hole grade 3. Mm-hmm. Okay, so now we're going to proceed with the ILM peeling.
Okay, we're going back to the normal microscope image. No OCT.
Please switch to the microscope image.
And as you peel, we'll try the OCT for a second to showcase the depth of the membrane.
Yes, we just need to clear the cornea and just give me some more viscoelastic.
Now, when talking about intraoperative OCT and intraoperative 3D microscopy, how has that changed your surgical decision making?
Well, I mean, the intraoperative OCT is still under my review, but 3D microscopy really helped me not only operate the difficult, the easier cases, but also helped me operate more difficult cases because I have a better angle of, a better wideness of view.
Mm-hmm. And how would you say has the Artivo changed the way you perform vitrectomy? You're not slouching anymore. You're basically sitting back, like
yes,
you're in a lounge chair.
Oh yes, I feel like I'm in a lounge. So now let me just be very still here. I will hold my breath now.
What is the average thickness of the membrane here?
Oh, it's just like less than 10 microns. So you see, the ILM is going off. Yes, that's very nice.
All
so
right.
Now I can, please give me the 27 gauge Charles. So I will use now this technique to try to close the hole by aspirating. Okay, I need to lower the infusion pressure. So I will try to close the hole on the table. As you can see, I'm aspirating the liquid over the macular hole very gently.
And you're attempting to use suction to close
yes.
the connection of the hole.
Yes, I need forceps, please.
And would you be able to use OCT to guide your hands, or to just check the end result?
Well, yes, I could use OCT to guide my hands, but in this case, it's really not necessary because I can really see where the remnants of the IOL are. Yes. So now again the brush. This particular hemorrhage is normal after when you remove the ILM.
Infusion pressure 25.
Okay. So now let's try to close it.
You're just using pressure and suction?
Yes, I'm actually just using suction to try to close the hole.
Mm-hmm.
It's like a massaging.
And what is the expected end result of macular hole repair?
Well, it's very good, but in this case where the macular hole was grade 3, almost grade 4, it's, I mean, maybe we could gain like 1 or 2 lines of vision, but that's it. And so as you can see, now the macular hole is much smaller than it was previously, and the edges of the hole are relaxed. So what I'm going to do now is to restain with the brilliant peel so that I can enlarge the area. But basically, I mean, you saw everything that I wanted to show. So my suggestion is, yes, okay, we can, okay, let's just see the OCT scan. But basically, I think we can go to the discussion. What I'm going to do is I'm just going to enlarge the area of the peel, and then I will put the gas tamponade and do some 360 laser, you see? So now look how the edges of the holes are actually
touching.
Well, they are not yet touching, but they are not under tension anymore, which is great.
It's very nice.
See, there is still a hole there, but we remove the ILM, and then this can be clearly seen on this OCT scan.
Okay.
Yes.
Professor Lazić, thank you very much for your time, and I will go join the panelists.
Yeah, sure. Okay. Air.
Here we are, ready to thank you, Ratko. That was a magnificent view of the surgery. Thank you for showing us this new technology. And now we will switch to the discussion part. We have already some questions raised. Okay, Professor Gabrić, there is a question from the audience till we get questions, which ask you whether you have felt any difference when implanting Synergy Toric versus Synergy that you have used before, like sense of the lens, whatever.
I didn't feel any differences between the Synergy and Synergy Toric, but it's very important that you care about the positioning of and mark on the lenses to put on the position which is marked on which position is cylinder.
Okay, and then one very interesting point, you already mentioned your own surgery and your own eyes. How did you decide which lens to use? Of course, it depends on the availability of the lenses on the market. And how would you compare the two of your eyes? How would you compare the vision that you have in your eyes, knowing that you have Symphony and Synergy technology in 2 eyes?
I can choose every lens is what I try. The first lens is what I implanted in 1999 was silicone array. It's a multifocal with 5 zones. After that, they produce resume. After that, the Alcom performed the diffractive lenses +4. After that comes the Johnson Johnsona with diffractive lenses +4, +3, +2.75, +3.5. And I decided, I tried the Zeiss lenses, I tried the fine vision, and I decided, because what I do for myself, and I decided to do the Symphony. And when I was very satisfied with Symphony, which was performed 10 years after the LASIK surgery, I was very satisfied. Very satisfied. I didn't feel any disturbance. I really enjoy. When I first time operating, after 24 hours, I operated the people in my operating theater. The second eye, I operating during the Corona time to improve the people to make the clear corneal clear lens extraction to get the better vision. With Synergy, I can see excellent with distance vision, intermediate vision, and near vision. But with Symphony, I see excellent for distance vision, excellent intermediate vision, and little bit slowlier or harder can read Jagger 1. Jagger 2, it's on my vision. But I prefer the transparent lenses, not yellow lenses. That is the main, for me, problem with Synergy. Synergy, I prefer the Symphony because it's a transparent lens. But I didn't see any problem. For example, many doctors speaks about the halo, the glare. It's a question of your mind. If you have to be in a solution, you will be in solution. If you have to have the problem, you will see always the problem. I'm very known. I didn't tell. Please don't tell to police. I drive my car more than 200 kilometers per hour during the night. I have no the problem. When I'm so tired, I see a small halos about the red lights. Yellow lights on traffic light is 50% less, but green lights, I have no seen any halos and glares.
Okay, next question is whether you have done surgery on other eye surgeons with this technology and what is the feedback? So where did you implant Synergy Symphony to other eye surgeons, and what is their feedback? How satisfied are they?
I told before, the main neurosurgeon in Croatia received the both eyes, the Symphony. In those cases, I performed small myopization. For dominant eye, I put it 0.25. And for non-dominant eye, put it 0.4. And he is perfect satisfied. He told me, I see like the young guy when I was 18 years, 25 years. The main cardiosurgeon received the 2 Synergy. He transplanted more than 50 eyes, more than 50 hearts in the cardiosurgeon. It's a very famous in world today, and he worked without, and amazing. He told me, I didn't know it. I fear before to perform this operation, I have fear. But now he's very satisfied. It's very important that I told you. The new technology is for the new generation. All doctors is doctors who promote the old technology. If you compare with telephone, mobile phone, if you see the people today, could you imagine the people that they wear the Nokia? It's not possible. Everybody has the modern telephone and modern technology. Also, doctors which wear the spectacles couldn't presented the new technology. I was the guy who was the youngest guy and have the spectacles. And I think always I so young, I look seriously, this and that. When I remove my spectacles and perform the LASIK surgery, people believe me. When I perform the Synergy and Symphony lenses, people believe me. It's very important that you believe in your technology. After that, you have to solve some problems with small tricks, with position of the incision, with position of astigmatism, managing with small tricks which you need to know when you work with.
Okay, thank you very much. I think we have Dr. Andreas from Johnson Johnson addressing us and joining us. Please do join us with your voice and with your opinion and questions, whatever.
Thank you very much, Professor Dekaris. Here I am. The video is not open, but we received also a few questions. So one of them is addressing what about patients suffering from dry eye or MGD, but at the same time asking for premium IOL. What are you doing before surgery with these patients?
It's very important that you recognize this type of patient before the surgery. If you have the problem with quantity of the tears, it's a first sign that he will not be satisfied. If you he has the problem with quality of the tears film, T-BAT, it is not good to perform this surgery because this type of patient are not satisfied. If you spend enough time to interview your patient, to measure all precise all diagnostic need, you will not make mistake. If you have some refractive surprise in the beginning, you have to have, for example, excimer laser. It's very important how to centrate the intraocular lenses, Synergy or Symphony or any other. I perform small part of the myostat to decrease the pupil, and I centrated, if you see on the second operation, how this pupil constructed about the center of the lenses. Many pupil especially hyperopic cases, is little bit decentrated to the nasal. Myopic sometimes is little bit decentrated to the lateral position, on temporal position. It's a small tricks which is important that somebody who has experience to tell you to escape from the problem.
So there's no kind of pre-operative treatment of dry eye for these patients?
Yes, we doing the preoperative treatment. We doing the LipiFlow treatment, and when we increase the quality and quantity of the TF film, we will after that doing the surgery.
Okay, thank you very much. There's also a question coming up from the chat to Professor Lazić about the, I'm just reading, don't you feel a very unstable anterior chamber on performing the extraction of the lens? So does it have any impact on your retina surgery?
Dr. Lazić entered in the operating theater to show you how it's possible to do combine the anterior segment and posterior segment. And he performed the first vitrectomy, basic vitrectomy, and after that he going to perform the operation. In the case when he worked normally, he do the first surgery, cataract surgery, and after that going to the posterior segment. Now he had the flow inside of the back of the eye, and this flow decrease instability, produce instability of the anterior chamber. But he done great surgery.
Yeah, really great. All of you really great. So we have seen a very nice case from Dr. Bohač on femtoLASIK, and you may now receive more and more patients post-LASIK that are becoming candidates for cataract surgery. What's your what kind of lens do you give to these patients, that these post-LASIK patients that are now requiring a cataract surgery?
It depends on the cornea and posterior segment. Nowadays, LASIK surgeries are leaving the nice and smooth corneas, so basically we can put multifocal IOLs if we have a good cornea over the pupil, so if we don't have some steep islands or irregularities. Otherwise, in all myopic cases from the 10 years and before, we are now putting eye hands, because to some extent is neutralizing the positive spherical aberrations for the high myopic treatments, and the patients are getting excellent distant vision and some intermediate. For hyperopic patients that were treated for +4, +5, depends on the amount of negative spherical aberration in the eye. So we are putting either aspheric lenses to those patients if they're not fit for multifocals, or even in some of those cases we are putting eye hands to enhance actual near visual acuity, because their negative spherical aberration together with the eye hands is giving them near vision sometimes almost equal to multifocal lenses.
Okay, perfect. Thank you very much. And then another question maybe also addressed to you. A question about the difference between SMILE and smart sight.
The difference between SMILE and smart sight, both of them are lenticular extractions, so we are basically taking refractive lenticule out of the cornea underneath the cap. So the basic surgery technique is the same, it's just coming from the different companies. So SMILE is from Zeiss, and Smart Sight is coming from Schwind company, so they had to change the brand name. And in comparison to Zeiss, Schwind company puts some built-in eye tracking device inside the laser and put the cyclotorsion control. So they're expanding the good results to the astigmatic patients also, because from the SMILE time we knew we had an excellent results on myopia from -2 and above. We had a good control of aberration, we got nice wide optical zones, but we were failing in astigmatism. With the Schwind company now we will be able to treat astigmatism also.
Good to know, also for us. Thank you very much. So
You're welcome.
we have seen a very great case of implanting a Technis eye-hands in a retina patient with a macular surgery. So what are in general the patients that in your premium clinic are receiving Technis eye-hands?
So the patients that receive eye hands, and in our clinic we have multiple levels of cataract surgery types. We segment them into monofocal and multifocal. The multifocals are segmented into premium and super premium, where premium would be your Johnson Johnson Symphony and low ad lenses. And then the super premium would be Synergy and Toric multifocals. When we talk about monofocal surgery, most patients choose monofocal probably because of some eye pathology, and not because of they don't want better or can't get better. So in general, we almost don't do normal A lenses anymore. We try to sell the Eyhance lens more. We don't sell Eyhance as a non-monofocal lens. We tell them it's a monofocal lens, you will see great up far, but you might be able to see some intermediate and near. But we already know from the 1500 implanted lenses that it's not true. If you play around with the myopization of the non-dominant eye, you can achieve perfect vision 20/20 up far and J1 near when you perform bilateral surgery. Now, we don't consent patients differently for Eyhance than other monofocals. We promise nothing. That's why Eyhance is such an amazing product, because you're promising nothing except good vision up far, and they gain so much. With multifocals, you set the expectation here. And if you miss, even just a tiny bit, they're unhappy. With monofocal, you're promising this, and with Eyhance, you're giving this. So this difference, this gain, is what makes people extremely satisfied. And the aberration profile and all the other issues, it just doesn't exist with Eyhance. That's why patients are extremely happy. And for us doctors, it's very easy to manage them.
So it's all, thank you very much. So it's also a bit to the character of the patient and the mindset of the patient.
I received, in the beginning I was very skeptic with Eyhance, but I used many Eyhances after the LASIK surgery. And I noticed, and we noticed together, that we get it the better results than you declare. You declare 1.5 diopter for the intermediate vision, but we measure, we get it in many cases, that the 30% cases we get it that they see the 1.0 on distance vision, Jagger 2 to Jagger 1. I couldn't explain, but it's a really present situation. And I gave to my younger doctor to collect all data that we presented. Was the reason that people can see better than the factory declared.
Perfect, thank you very much. So, as you implanted today 3 Synergy Toric lenses that are based on a new platform of Toric, did you experience any difference using this new platform of Synergy Toric versus the old platform of Toric lenses? Is there any difference that you experienced? The old Toric version versus the new Toric version?
I didn't notice any big differences. But I will see in the future what is the important. The most important, lens is stable. If you are stable, if this stable, it's a great thing for me. I can do the limbal relaxing incision and solve the problem. But for the bigger eye, myopic eye, we perform more than 25% people who has implanted the Synergy plus 10, 12, 14. It's a bigger eyes. I think and they have the astigmatism. It's a big problem with small lenses. But in those cases, we use the Zeiss lenses Toric and put it also the capsular tension ring to prevent the rotation. And I have to tell you that Zeiss lenses has more PCO than the Symphony and then the Synergy.
Okay, good to know. As our clinic has a bit of history in mixing and matching lenses, do you have experience, and you have your personal experience of mixing and matching Symphony and Synergy? Are you still applying that approach? Mix and match of Symphony and Synergy?
No,
I do a lot of mix and match. I started with mix and match with Resume and with Technics or with Alcon lenses, which has, and 75% is very satisfied with mix and matches. But you don't know which 20% will not satisfy. And that's the problem with this. We also matches for example, Panoptics i Synergy. We matched Panoptics and size. We matched Symphony and low end. Many times, depending how the profile of the patient, if the psychological profile of the patient is simple, they are very satisfied. If the problem is very complicated, they always compare differences between two eyes, and you had headache with this patient. It's not always easier to do this. And I don't recommend it too much experimentize for the people who has no experience with this.
Receiving just a question from the chat about what IOL do you prefer implanting in high myopic patients?
My case is what I do, the myopic cases is a plus 10 synergy in both eyes. It's a high range what I go down there. The most unsatisfied person is, for example, if they have the -3. -3, it's this patient has no good vision for a distance, but they can read on the near. More than 3, 4, 5, 6 is okay, but it's necessary to do the very precise diagnostic of posterior segment surgery. And we have in 1,300 cases, only one case which has getting the ablation of the retina after more than 1 year, and he is not the myopic patient.
You see, when you regarding the reading ability, do you see or do you learn from any experience from a patient in the reading ability of trifocals versus Synergy, especially at low light conditions?
I'm very satisfied with low light conditions. Synergy is perfect. I can see, and I tell the people that I can see better on the left eye where I have the Synergy in low light condition than in the right eye when I have the Symphony. Synergy is better for low light condition than the Symphony.
And compared with trifocal lenses, the biggest advantage with the Synergy is when you're telling the patient about the trifocal lens, you have to start by explaining that there are just 2 positions where they will see good. So position 1, reading. Position 2, computer. Everything in between is blurry. Now, this is a big issue because people before, when they used to have their own manifest refraction, they had a near point and a far point which they learned during their 50 years of life. And now you're giving them these 2 fixed points. With Synergy, you don't have to spend time explaining it because the continuous range of vision, and I personally have done over 200 defocus curves on Synergy, so I can attest to that, is flat. You don't have to hunt for focus. So when you're talking about trifocals, everything good about them is okay, but these gaps in focus are just going to be the end of that technology, in my opinion.
And there is also one other thing. When you have a problem with the trifocal for the near vision, it has such a loss in contrast and in the light distribution that if patient cannot see on near, you cannot add the correction to enhance the near vision to that patient because +1, +2 just simply doesn't help in low light conditions. With the extended range of vision, either Symphony or Synergy, if a patient is struggling with the J1 or J1+, you can add +0.5, +1, and you will enhance reading performances of that specific particular small print in specific light conditions.
Oh, thank you very much. Stimulated by our discussion about mix and match, we also received a question from an attendee. Do you ever mix and match eye hands on the dominant eye and Synergy?
Yes, we done this several cases when we have the problem, for example, with cornea, with astigmatism, with keratoconus, with amblyopia. But we try to perform the small seria. Patient, we will put it the eye lenses in a dominant eye and non-dominant eye to put the synergy. We will have the results very soon.
Okay. Exciting to learn about that. Thank you. And we received another question, a completely different one, because you're a really large clinic with so great, well, experience and doing so many premium technologies. Did you change anything due to the current COVID-19 situation in your clinic? How you manage your patients, how they have the patient flows?
Well, we shouldn't have mentioned this topic at all because it's a little bit depressive, but I'll try to answer. So in the operating theater, nothing really changed. We are working every day in a very, very clean ambience. What we have focused a little bit more is that not to have in our relax room or waiting room many patients. So they have to sit apart at least 2 meters. So we are even more cautious when we send them to the operating theater. The advantage that we also have that we are outpatient clinic 100%, so we don't have problems that general hospitals have. And in outpatient service, we are also very careful not to have many people in the waiting room. So coming to the Klinici Svjetlost, at the entrance, the temperature is measured in each single patient, and the patient cannot go upstairs till the appointment time. So we always have our waiting rooms half empty. So, and the addition measure is also that we have breaks in between. So between 1:30 and 2:30, we stop all the activities and the whole house is cleaned. So this is something definitely new. And thanks, we are very, very happy up to now. We did not meet this COVID virus in our clinic, and hopefully it's going to stay that way.
Yeah, so thank you very much for sharing that with us, because I think it's really exciting also for the audience to learn how a really large clinic, an effective clinic like yours, is handling that situation. Because that is a question for all clinics, and it's great to learn from a perfect example as yours how to do. So thank you for sharing. Another question regarding, I'm just reading here because it's pretty long. So in a hyperopic patient with amblyopia and visual acuity of less than 0.5 on one eye, are multifocals a choice?
No, in these cases we put it the eye hands, and the other eye, which is the normal, we put the multifocals. We had a lot of patients like this.
Okay. That was also the second part of that question, exactly for doing so. Okay, just wondering if there's any more from the chat here. Doesn't seem so. So with having said this, I think we are pretty in line with time and coming to the close of our session. So, hey, that was really impressive. So it was really a great afternoon. So impressive and exciting to see your surgeries and to learn from all of you in the discussion. So many thanks, Professor Gabrić, Professor Dekaris, Professor Lazić, Dr. Bohač, Dr. Gabrić. Congratulations to your surgeries and sharing all your surgery experience with us. It was really great. And I think also from the audience across Europe, it was really exciting. Thanks also to your teams in the OR, all the people in the background to help you, and all the technicians in Zagreb, and also technicians there managing the broadcast from Zagreb to across EMEA. Many thanks to all of you. Many thanks also to the audience who joined this webinar all over EMEA and sent the questions to us. Many questions that we received. They were really stimulating our discussion. So many thanks to everybody. For those who joined in the audience, I would like to ask you to complete a very little questionnaire at the very end that is showing up after the webinar to let us know and give us some more inspiration for the future. So thank you very much for this. With that, we are closing the program of today and would like to thank you again for that great afternoon, that great experience. Have a great evening. Thank you, everybody. Goodbye, and looking forward to cooperating with you next time. Thank you very much.
Thank you.
Thank you.
Thank you. Goodbye.
Bye-bye.
Bye-bye.
Thank you.
For a few months, we will organize another meeting.